All right, so let's get the ball rolling. So we've got Super Doc Brendan Yee, who works with us, and we're very lucky to have him. He's a senior staff specialist at RPA, and he sees almost all of our PWS, almost all of our patients. He sees most of our patients with PWS. He is a respiratory and sleep physician, has a particular interest in respiratory failure and sleep disorders. He is also a clinical professor and head of discipline of medicine, sleep medicine at Sydney Uni. And he is also affiliated with the Woolcock Institute of Research and an honorary professor at Macquarie Uni.
Thank you.
Welcome.
Thank you, Tanya. Thank you for the organisers for asking me to speak. I'm an adult respiratory physician, so I feel a bit of a ring in here. So I'm not an endocrinologist or geneticist or obesity expert or Prader-Willi expert, but I have been seeing adult Prader-Willi patients now for close to 20 years and working with Georgina and Tanya in the Prader-Willi clinic. So I guess it's kind of clinical experience more than anything else. I guess the reason why I've been asked to speak is talking about some of the respiratory and more importantly, the sleep complications that patients with Prader-Willi may get, particularly as they get into adulthood. I'm not a paediatrician, so I want to make sure that's clear. So anyone asks me questions about toddlers or anyone less than 12 or 13, it gets a bit grey for me. So just adults only, thank you. So what I want to do is talk about some of the common sleep disorders that we see, some of the things to look out for, some of the treatment options, and I guess talk about some of the evidence out there in terms of how we treat these common sleep disorders. So we know that sleep disorders are common. We know it can affect patients, Prader-Willi patients' daytime functioning. It may have a role in terms of some of the metabolic and cardiovascular complications, and it also may affect some of the psychological and cognitive aspects in terms of their daytime as well. And there is evidence to suggest that maybe having a chronic sleep disorder or chronic respiratory disorder may affect life expectancy as well, particularly in Prader-Willi patients that have nasty complications that we'll touch on later on. I'm going to talk a bit about the pathophysiology of some of these sleep conditions, and I guess the bottom line is a lot of these conditions have not been teased out that well in terms of sleep disorders, and we're extrapolating a lot of our information to Prader-Willi from, general sleep populations. There are some animal models. Beg your pardon. There are some animal models that are interesting in terms of sleep disorders that I'll touch on later on. So symptoms of Prader-Willi may be associated with disordered sleep. So as I mentioned, neurobehavioural, physical health and daily living may be impacted by having a chronic sleep condition or chronic sleep disorder. And that may be things like poor concentration, motor and balance concerns, to poor feeding or food seeking, to poor stamina and fatigue and daytime sleepiness, which is a very common manifestation that I see. So what are the common sleep disorders? I think maybe up to 40 to 50% of patients with Prader-Willi syndrome will have a sleep disorder, of which sleep disordered breathing is a very common complication. Now, what do I mean by sleep disordered breathing? So there's various sleep disordered breathing conditions out there. And I think it's important just to know the differences. I'm not going to talk too much about the nuances of this, but just be aware. So there is a condition called central sleep apnea. Now, this is probably more common in younger children, especially with neonates as they've developed. And that's a condition where patients don't breathe. So they don't breathe at night time. They have these pauses in breathing. There's no signal to breathe. The most common type of sleep disorder breathing we see is obstructive sleep apnea. And that's the one that everyone knows about, the snoring, the choking, the gasping. And it's really due to obstruction to the back of your throat. And that's more common as children age and become adults. There is a rarer complication of sleep disorder breathing called sleep-related hypoventilation. And these are the patients that I get worried about. So these are the patients that have under-breathing at night time, such that their oxygen level and carbon dioxide level are abnormal during the night and also during the day, and it puts a lot of strain on the heart. These are the ones that keep me up at night. Okay, thankfully this is not a common complication as we're dealing with the other aspects of Prader-Willi. And sometimes patients can get a combination of these types of breathing. So they may have a little bit of central apnea, they may have a bit of obstructive sleep apnea, or they may have obstructive sleep apnea and hypoventilation or underbreathing. The etiology of these conditions are multifactorial, but things like alterations in the brain in terms of chemosensitivity may be an important aspect to it, as well as the role of weakness in the muscles, obesity, and I guess craniofacial makeup. Central sleep apnea, as I mentioned, is common in infants less than 2 years of age, and it usually goes away by itself. So the vast majority of children that have central sleep apnea, if picked up, it will usually get better by itself. And it probably just reflects the fact that their respiratory system, their respiratory control just takes a little bit more longer to mature. So typically with central sleep apnea, you have periods where there's no effort to breathe. And that's in contrast to obstructive sleep apnea, where people are trying to breathe, but the airway's blocked off. So central sleep apnea, no signal to breathe. And it's usually due to a control of breathing abnormality, maybe at the level of the brainstem. But as mentioned, it usually gets better by itself. You don't need to treat it usually, and I hardly ever see it in adults with Prader-Willi. What do I mean by central sleep apnea? This is a little cartoon. I don't want you to be sleep experts and read sleep studies, but I'll get you to look at these bottom lines here. So these represent the breathing patterns of people. So they're measuring the chest movement, they're measuring the tummy movement, and they're measuring the breathing, the flow rate. So what you can see here is there's a period here where there's no flow, so there's no breathing, okay? And we're trying to work out... Sorry. So you can see in the top two lines, they represent breathing. So you can see here there's a period during the night where there's no breathing. But if you look at the bottom lines, this represents the thoracic movement and abdominal movement, and there's no movement of the chest or tummy. So there's no effort to breathe. And that's what we call a central sleep apnea. Okay? Common in children, toddlers, but usually grow out of it, and usually we don't need to treat. What about obstructive sleep apnea? So this is the more common form of sleep disorder breathing that we see. And there's many reasons why Prader-Willi patients are more prone to getting obstructive sleep apnea. As I mentioned, there's changes in their adenoids and tonsils. There may be weakness in their respiratory muscles or weakness in their throat muscles, which means that their throat is more collapsible at night time. There may be some facial dysmorphism, which increases your chance of narrowing of the upper airway, and also the effects of obesity as well that may affect the breathing at night time. The classic presentation of obstructive sleep apnea is the daytime sleepiness. There may be some behaviour-like complications associated with it and poor cognitive, concentration, but also the loud snoring and choking episodes. How do we diagnose sleep apnea or obstructive sleep apnea? We generally need to do a study. We generally need to do a sleep study. Now, there are different types of sleep studies out there. The most common sleep study that we think about is the ones that, when people have a sleep study in hospital, where they have all the electrodes and stuff on, that's called a level 1 study. That's the gold standard. But it involves sleeping overnight in a sleep laboratory in a hospital where you're monitored. Okay, and it's quite labour intensive and it's quite expensive, and there's wait lists for that. There are kind of more simplified ways of diagnosing sleep apnea with, less involved type sleep studies, and they are called level 2 and level 3 and level 4, and they can be very useful in certain populations. But the only problem with these lesser sleep studies is the information that you get is less as well. Okay, it really depends on individuals. So I think when I see a patient that needs a sleep study, we have to look at the balance of the convenience of having a sleep study in a laboratory versus having it at home, but we can talk about that. So what's the difference here? So this is a person having a sleep study. This is their hypnogram, and I guess what I want you to focus on here is, remember that last case, there was no flow, okay? There was no flow, so this person's having an apnea, but you can see here there's some effort to move. There's some effort to breathe. So unlike the central apnea, where there's no effort to breathe, this poor person is trying to breathe. But the problem is that their throat is blocked off at night time. And that's what obstructive sleep apnea is. Okay? And if you can, consequence of obstructive sleep apnea, you can see that there's a drop in oxygen level, and there's fragmentation of the sleep because you're doing this frequently during the night, and that has daytime consequences, or I guess downstream consequences. So when we look at a sleep study and we diagnose obstructive sleep apnea, then there's a few things we typically look for. We look for the frequency of the apneas during the night. We look at the degree of low oxygen level, what we call hypoxemia, and we see what the sleep looks like. What does the sleep architecture look like? So typically when we sleep, we should have normal sleep architecture, which is these runs of non-REM and REM sleep, and we typically have about 4 cycles of that throughout the night. If you've got a condition called sleep apnea where you're doing this every minute, even more, that disrupts the sleep. It disrupts our sleep architecture, and it may have flow-on effects. And there's a lot of interest looking at sleep fragmentation from sleep apnea on cognitive function and other neural networks as well. So, we've made the diagnosis of obstructive sleep apnea. How do we manage it? So in children or pediatric obstructive sleep apnea, one of the most common causes is having large tonsils and adenoids. So if you remove large tonsils and adenoids in children with obstructive sleep apnea, it usually improves, but not always the case. So in children that have had tonsils and adenoids removed for obstructive sleep apnea, they still may get residual obstructive sleep apnea symptoms. They may still have residual obstructive sleep apnea. So it's not a cure on everyone. If patients have had an adenoid tonsillectomy and still have symptoms of sleep apnea, or you see an adult with obstructive sleep apnea and their adenoids and tonsils are not particularly enlarged and they're symptomatic, then we probably need to treat these patients. And what we tend to use is something called a CPAP machine. So a CPAP machine, I think most people know what a CPAP machine is. So it's that mask that you wear connected up to a hose, connects to a machine that blows in air to open up your throat. Okay? Now you're going to say, no, who's going to use that? And we know in real life that CPAP use is not great. And I've got to be honest. And although in the perfect world we want everyone using CPAP, we know in the real world it's probably about 60 to 70%. That's in normal obstructive sleep apnea patients. But in Prader-Willi patients, there's actually evidence suggests that the compliance is similar. Okay? So that means that we should be, and if patients are requiring a trial of CPAP, we should be doing it. Okay? So the compliance rate with CPAP is similar to the general obstructive sleep apnea population, if you look at reviews and audits. We know that obesity and obstructive sleep apnea go hand in hand. There's a very strong relationship between the two. So the bigger you are, the more likely you're going to have obstructive sleep apnea. If you lose weight, obstructive sleep apnea improves. So management of obesity is very important in terms of obstructive sleep apnea, let alone Prader-Willi syndrome. Occasionally in patients that have the really severe form of sleep disorder breathing called nocturnal hypoventilation, where your breathing becomes so shallow that your oxygen level is low for the whole night and during the day, or your carbon dioxide level is very high, then sometimes we need a bi-level device, which is a much more fancier form of CPAP, and that's a little bit more complicated. There are novel treatments out there. Most of these have not really been studied in systematic fashion in Prader-Willi syndrome, but in general OSA populations, there may be a role for things like mandibular advancement splints. These are dental appliances you wear at night time that push your jaw forward at night time, and they can be helpful in patients. In America, but not in Australia, they're using what we call hypoglossal nerve stimulators. It's a pacemaker of the hypoglossal nerve. This is a nerve that supplies the tongue. So what you're doing is you're pacing the tongue muscle at night time, and by pacing the tongue muscle, it activates the tongue, and theoretically that opens up the airway and makes the breathing better. We don't have that in Australia at this stage. Occasionally, you only have patients that may have what we call positional obstructive sleep apnea. So they only have sleep apnea when they're lying on their back. And maybe 10 to 15% of patients with obstructive sleep apnea will have this. So it's important when we do a sleep study that we look at body position. Okay, so if you're lying on your back, sometimes you're more vulnerable to having obstruction in your breathing because your throat's shaped like an oval. So in about 10 to 15% of patients with Prader-Willi, all they have is what we call positional sleep apnea. And if you change the position at night time, that's the only treatment you require. So the nocturnal hypoventilation, is the one that I get worried about, and that's when people underbreathe at night time. It's not a common complication, but if you do have this complication, it may lead to other problems. And the other problems include respiratory failure and cardiac failure, recurrent hospital admissions, and generally speaking, the prognosis is quite poor. It is treatable though, and obviously treating the sleep disorder breathing at night time with a bi-level device can be very helpful, and looking at the other risk factors that can affect the breathing, such as weight, etc., can be helpful as well. So that's sleep disorder breathing. Central sleep apnea, common in children, usually goes away, not usually a big problem from our point of view. Obstructive sleep apnea is quite common, particularly in adults with Prader-Willi syndrome. It's assessing the symptoms, it's assessing the severity based on what we find on a sleep study, and then managing that depending on symptoms, other medical complications, and what we see on a sleep study. And there's various treatments for obstructive sleep apnea. A more severe form of sleep disorder breathing is the underventilation, thankfully not common, but something to look out for. And if you do have nocturnal hypoventilation, they must be managed in a multidisciplinary clinic. The other common condition that we see in Prader-Willi syndrome is daytime sleepiness. So this daytime sleepiness is extremely common, and it may be associated with sleep disorder breathing, the conditions I've talked about, but it also may be associated independent of sleep disorder breathing. And what I mean by that is you may have a Prader-Willi patient. They don't have sleep apnea, but they're sleepy as heck. So it can be a complication independent of sleep disorder breathing. And the other caveat is if they've got sleep disorder breathing and you treat their sleep disorder breathing, they may be still sleepy. That suggests that maybe they've got two problems going on. Not only the sleep disorder breathing, but they've got a condition that's making them sleepy. So what do I mean by sleepy? So there's a lot of interest out there, but unfortunately it's an area that hasn't really been extensively studied that well. But we think that Prader-Willi patients may have this narcolepsy-like phenotype. So narcolepsy is a pretty rare condition, and it's a condition where patients are extremely sleepy during the day. And typically what happens with narcolepsy is that they get a loss of what we call the orexin pathway. So in narcolepsy patients, if you measure the orexin in their brain, it's gone. And orexin is really important for maintaining wakefulness, and it also has some role in terms of appetite and metabolism. Now, in Prader-Willi patients, where they've done experiments looking at whether or not orexin is knocked out, what the hypothesis is that maybe the orexin pathway is a little bit diminished, but you don't get low levels that you get with narcolepsy. So that's why we say it's a narcolepsy-like trait. But despite that, they get the hypersomnolence, the sleepiness. And if you do objective testing on Prader-Willi patients, there's a reasonably high percentage of patients will have a positive test. So one of the tests that we do to diagnose narcolepsy is a thing called an MSLT, and that's called a multiple sleep latency test. And it's a test where we get people in a quiet room, we put them in a quiet room for 20 minutes, and what we do is we say to the patients, go to sleep. We do that at 8 o'clock, 10 o'clock, 12 o'clock, 2 o'clock, and 4 o'clock in the afternoon. Most people will not sleep, okay? But in people that have narcolepsy, they will fall asleep within a few minutes, okay? And they do that in all the nap periods. And that's what we call positive MSLT. The other caveat is that not only do they fall asleep, but they go into REM sleep very quickly. So typically for me, it takes me 60 minutes to go into REM sleep. But if you've got narcolepsy, you go into REM sleep very quickly. Remember, REM sleep is the dreaming sleep, and it's a sleep when we feel paralyzed. So typically patients with narcolepsy have this dreamlike, vivid dreams as soon as they go off to sleep, and they feel paralyzed as well. Now, Prader-Willi patients can get some of those traits, okay, and they can have a positive MSLT. So it's very similar to narcolepsy to some aspects, particularly clinically. So, as I mentioned, the orexin pathway is really important, but we feel that the orexin pathway in Prader-Willi patients is probably reduced, but if we measure the orexin levels in the cerebral spinal fluid, it's generally normal to low, but not absent, which is what you see in narcolepsy. So there's been a few studies looking at this kind of narcolepsy hypersomnolence trait in Prader-Willi patients, and it's not that uncommon. But as I mentioned, if you look at their orexin levels, which is crucial for maintaining wakefulness and may be important in terms of appetite, it's generally normal or low as opposed to absent. Now, if you have a patient that has this kind of narcolepsy-like trait, the question is, what can you do about it? So there are some treatments. So modafinil is a wakefulness promoter that's actually been around for probably 30 years. It's not an amphetamine, so it's not really classified as an amphetamine like dexamphetamine or methylphenolate. It's a wakefulness promoter which has a slightly novel action. Though if you drill down into it, one of the actions of it may be a little bit similar to amphetamines. The advantage of modafinil, it's been around for about 30 years and it's pretty well studied in the narcolepsy population, and it's kind of first-line treatment. It can cause headaches, it can cause a skin rash rarely, and it can interact with the oral contraceptive and you can't get pregnant with it, but it can be a very useful treatment for helping people stay awake. Now, is there any evidence of using modafinil in Prader-Willi? There is. So there are some case series showing that if you give patients with a narcolepsy trait, you put them on modafinil, they do get improvements in their quality of daytime functioning, they can stay awake, but it's not a cure. If you look at the effectiveness of these medications, you probably get about a 30, 40, maybe 50% improvement in sleepiness, objectively. So it's not a cure. In the States and parts of Europe, they have used other medications to help maintain wakefulness. There's a novel agent called pitolisant. It's not available in Australia. It is if you live in Perth. It's on the formulary there. I don't know how it got there, but there's some rich politicians in Perth or advocates there. It's a novel agent that works on the histamine pathway, and the histamine pathway is one of our wakefulness pathways. And there's actually a small study showing that in patients that have a narcolepsy trait with Prader-Willi syndrome, they go onto this pitolisant, there's improvements in their daytime functioning. And the side effect profile is probably a little bit different from modafinil, okay? And I guess, if we were living in the States or Europe, it just gives you something else that we could consider. This is a study, a small study looking at the effects of modafinil in Prader-Willi patients who have a narcolepsy trait. What they looked at here is before and after. It's a very simple observational study. So the Epworth Sleepiness Score is a subjective questionnaire scored out of 24. 24 means that you're falling asleep everywhere, okay? 0 means you don't fall asleep. So basically, the higher the number, the more sleepy you are subjectively. So with modafinil, you can see there's a significant change. And there was no change in weight with giving modafinil for these patients. So, when we see patients with Prader-Willi syndrome, it is a multidisciplinary approach. I think you need sleep and respiratory experts involved. Thank you. I think validated questionnaires in Prader-Willi syndrome and sleep disorders are not available. So a lot of the times it's just based on talking to you, talking to the patients, talking to carers, etc., to get the history that you need. I think testing is important, and choosing the right tests is crucial, and interpreting the tests is important as well. I think there's a role for home testing in Prader-Willi patients. I think that's probably underutilised, but just know the limitations of home testing. And I think there are treatment options for patients, and I think it's important to know that. It's not just CPAP, it's not just modafinil, there are other things that may be available that may be useful. I won't talk much about growth hormone because I know time's up, but I think there is a slight, concern about growth hormone in Prader-Willi, but the evidence is not that strong, and I think it's making sure in patients before they start growth hormone that they don't have untreated hypoventilation or obstructive sleep apnea, in which the case growth hormone may be not good for them. But generally speaking, growth hormone is very well tolerated, and I hardly see any complications from a respiratory or sleep point of view. The hypothesis is that growth hormone is it may make upper air obstruction worse. And there's Australian studies suggesting it was relatively safe, but screening your patients is important. But I think it's important to do serial studies to be sure. So in conclusions, I think the narcolepsy kind of trait, Prader-Willi syndrome, is something that is gaining a lot of interest. And the reason for that is we've got very good models of narcolepsy now. Our understanding of narcolepsy in the sleep world is quite strong, meaning we actually know what the deficit is. The other important thing is not just knowing the deficit, but there are some treatments now that look very, very exciting. So I look after narcolepsy patients. And in narcolepsy patients, as I mentioned, the orexin system is not existent. You measure the orexin in their cerebrospinal fluid, it ain't there. Obviously, one of the treatments you'll think about is why don't we replace the orexin? That's been difficult. That's not been practical. But there have been developments in developing things called orexin agonists. And these are medications that target the orexin receptors, which are right throughout the brain. And the preliminary studies have shown that if you give these orexin agonists to narcoleptic patients, they get a marked, if not a life-changing experience. I've never seen narcoleptic patients that have normal sleep and normal daytime functioning. We've done some very early phase 1B studies, and I've had patients cry because they've never felt so awake. And there's the only time in my practicing career where I had a patient who actually welcomed having insomnia. His partner wasn't, because he was on the phone all night to her, and normally he'd be falling asleep. So this is very exciting. Now, I'm not sure what the literature is, and I'm not sure what the developments are, but there's a lot of interest in these orexin agonists. And I guess it kind of makes sense in the Prader-Willi world, because, as I mentioned, these are treatments that improve sleepiness. It may also have metabolic effects as well, because we know in narcoleptic patients that they've got no orexin, they tend to develop obesity, because orexin is like an appetite suppressant. So there may be some metabolic effects of these orexin agonists. We don't know. It's still early days, but very, very exciting. In terms of sleep disordered breathing, it's important to identify this because it does have bearing in terms of their daytime function and flow-on effects. I think it's important if they have obstructive sleep apnea that we treat them with CPAP, but there are other treatment options available as well. It's not just CPAP. I talked to Tanya about the role of obesity management and GLP-1 agonists. That's very trendy in the sleep apnea world. There was a large randomized control study in adults with sleep apnea with obesity. You put them on tirzepatide, which is one of these new GLP-1 agonists, these incretins, and there was like a 20% reduction in weight after 52 weeks and about a 50 to 60% reduction in sleep apnea. That may be a game changer in the OSA world. And as I mentioned, the importance of multidisciplinary clinics. I'm lucky. I work with a great Prader-Willi team. I have great respiratory and sleep nurses, physiotherapists, scientists, and other clinicians that I work with. It makes a difference. So have we got time for questions? I'm happy to take some questions.
I'm just wondering if the orexin is also useful for cataplexy, so narcoleptic cataplexy.
Yeah. So, I mean, the orexin agonist story is, the orexin agonist is taking, it's not, very exciting field. These orexin agonists getting a lot of interest out there. There's a lot of pharma companies interested in these medications. There was a paper published in New England Journal of Medicine last year, and that's kind of our medicine journal Bible. If you publish in that, you've made it. From a physician point of view, not scientist point of view. So there was a paper looking at orexin agonists in narcolepsy. It was a phase 2/3 study. So it's, getting there in terms of looking at outcomes. What they looked at was patients with narcolepsy with cataplexy, so NT1. And what they found was you normalised their daytime sleepiness. It was normal. Their cataplexy reduced significantly. And it was a very, very positive study. However, the study was stopped prematurely. And the reason for that was 4 out of 70 developed liver problems. So because of that, the whole program for that drug, even though it was very effective in terms of narcolepsy, was halted. Okay? So these newer orexin agonists, obviously that has to be tested because we don't want liver toxicity. There was no deaths, and the liver function improved over a period of time. But because it caused that liver toxicity, that drug is completely stopped. So it did control cataplexy. It reversed all the manifestations of narcolepsy. And I guess the question is, how will it affect Prader-Willi? We don't know. It's very exciting.
And I also just wanted to mention that you can get pitolisant in Australia if you go through the hospital, can order it in for you if you have a diagnosis. My daughter's on it.
And
Depends on the hospital, I think.
Yeah. It depends. I mean, I work in a hospital that does not allow us, because of the budgetary, to put people on standard treatments like sodium oxybate. They refused. So it depends on your hospital. I guess if you make a case for it, you may be able to get it. In Western Australia, you can. Yeah.
All right, well, we better move along. Brendan, are you going to be here in afternoon tea, or do you have to dash off?
I'm going to go back to...
Oh, he's on call.
Yeah.
Okay, all right,
Thank
never
you.
mind. Thanks, that was great.